Good afternoon and welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to return or fill out and return the program evaluations at the back of the auditorium at the end of the program. Also, please remember to return the audience response clickers. Today, I have the pleasure of introducing Angela Long. Angela holds multiple degrees, including RN, BSN, CNBN, and CBCN. She has additional certifications in oncology, nursing infusion, mastectomy training, chemotherapy, and biotherapy training, and as I mentioned, is a certified breast care nurse and breast nurse navigator. She was previously the clinical services manager for Homeward Home Health, but is now the cancer care navigator at the Bliss Cancer Center. And she has kindly accepted the invitation from the CME committee to come today and update us on navigating breast cancer. Please join me in welcoming Angela.
Thanks. Thanks, Dr. Hallberg. Okay, Tim assures me this mic is on. Can everybody hear me okay? Got so many mics, I'm not sure what to do with them, but. So I have no disclosures to make. I do have an apology to make. I have allergies, so I'll try not to snuffle and lose my voice throughout the presentation, but outside of that, we should be good to go. For those of you that aren't aware, our Bliss Cancer Center recently received a 3-year accreditation as a recognized breast center through the NAPBC. And the NAPBC is the national accrediting program for breast centers, so we're pretty proud of that. And so we are now one of 8 recognized breast centers in Iowa. One of the components of being a breast center is navigation, hence our topic today. And thought I'd give you just a little bit of my background. I've been a nurse for 32 years, graduated nursing in Alberta, Canada, was in oncology for 7 years, and then got tired of the snow, so I decided to relocate to California, continued in oncology there, and one of the things that I became involved in was the NSABP tamoxifen breast cancer prevention trial, and so now it's kind of nice that I'm transitioned to working with actual breast cancer patients. Got a little bit tired of the perfect weather in California, so then I decided to come to Iowa, and I've been here with Mary Greeley for the last 22 years, brief detour in home care, but I'm pleased to say back with the oncology team and providing the cancer care navigation services. So hope to shed a little bit of light on our objectives today, talking a little bit about definition and role, so what I do, talking about benefits of the program, how to make a referral, and then most importantly, my fourth objective that's not listed is keeping everybody awake. So we'll see what happens. When I first took the role as navigator, obviously read the job description, thought it sounded like a real cool position, but what exactly do navigators do? Thought we'd start a little bit looking at definitions of navigation to start off with. So this first definition is from the Academy of Nurse Navigators. I'm not going to read it to you, but one of the things I want you to hone in on is removal of barriers and timely and appropriate cancer care. Okay. The second definition, this is from the COC, this is standard 3.1, and it mirrors pretty much the NAPBC navigation standard 2.2 that requires patient navigators. And so this one's a little bit different. I like the fact that not only does it talk about patients, but it talks about family and caregivers, and that unit is really who we treat, not just solely patients. And so you'll notice a little bit of difference. Nurse navigator as opposed to patient navigator. Is there a difference? And there is. Navigators can be nurses, they can be social workers, and they can be lay people. So depending on the background that they're bringing to the program, the role can change a little bit. Here at Mary Greeley, we have nurse navigators, so a little more of a clinical approach. I thought it was going to be like Will Ferrell and Anchorman and have my notes here on the teleprompter, but that's not happening, so I'll be looking down occasionally. But this is audience participation time. Going to see what you guys feel as far as when did patient navigators join the oncology team. Not sure how many people we have in the room, but You guys are still awake. I'm impressed. That's good. Okay. So a majority of you are saying 2005. I just want to give a little caveat that this slide, the answer is not really correct for Mary Greeley, but it was a trick question because it talks about navigators in general joining the team. So this also leads into a little bit of history of navigation as well. Oops. So as a physician, Dr. Friedman worked with underserved populations primarily in Harlem, and he became a recognized authority on the relationship between race, poverty, and cancer. And so he realized that by eliminating barriers to care, there was more timely access to screening, treatment, etc. Navigation Act was signed by President Bush in 2005, and that was largely based on Dr. Freeman's model. The last two standards of navigation I alluded to already in the previous slide, but since its inception in 2009, the NAPBC has required patient navigation. The COC, which is Commission on Cancer, has required navigation since 2015. So typically when a program or accreditation requires a standard, there's usually some evidence that shows that it improves patient outcomes. And we like to believe that that is, in fact, the case. So our program, we talked a little bit about 2005 when the Act was signed in to law. Mary Greeley's program was actually established in 2011, 2012, so pre-me. I joined the program in 2013. And some larger centers will have a patient navigator for each body system. Stoddard in Des Moines is an example of that. For the size of our center and the makeup of our patients, we decided that the primary focus was going to be on breast cancer patients, so that's largely where my attention is focused. Our goal is to see 100% of breast cancer patients. We do a really good job. We're probably in the upper 90s now, but again, part of today's education is to increase awareness of the program, get early referrals of these patients. So what about the other oncology patients that are having problems? We see those too. That's what we term as our barriers to care tract. And so any patient can be referred to us for issues, and we'll talk a little bit about what barriers these patients encounter as we go on. So our current structure, there's several models to navigation. Some facilities start their navigation in imaging and diagnostics. Mary Greeley and McFarland both do a really nice job of addressing that. They have staff that meet with patients and are very good in educating. So our program actually starts at diagnosis and through active treatment. In 2013, we started with 126 breast cases. We were obviously seeing patients before that time. But in 2015, we saw 153 breast cancer patients, and that is growing. So that's, again, one of the reasons that we're focusing on being a recognized breast center and providing that care. There's currently one navigator. You're looking at her, Cancer Care Navigator. Most of you probably know Mary Ellen Carreno. She's the clinical coordinator of the Resource Center. She is our genetic educator. She also provides navigation services, and both of us do survivorship care as well. So currently that's our setup. So navigation may vary as a result of individual patient needs, obviously, but really think about it in three phases. Initial contact. During that time, we're introducing what does the navigator do, how are they going to be involved in the patient's care, kind of establishing rapport with our patients. Follow-up visits, we try to tack on to already existing appointments. So if a patient is coming in for weekly chemotherapy, we touch base with them during those appointments, radiation consults. We try not to bring them back into the center just to see us. And we have nice proximity to the oncology area, so we can have patients come to us or we can go to them. So it's been a nice relationship. Survivorship is the summation of care. And in 2005, the Institute of Medicine released a report that largely said we weren't doing a very good job of transitioning our oncology patients back to their normal primary care. And so from that time, that's been an ongoing focus. At survivorship, what happens is the patients and families meet with us. We talk about what their diagnosis was, give them a summary of care, talk about short, long-term things that happen after radiation chemotherapy treatments, and then most importantly, what is their follow-up going to be for the next few years? And that's based on the NCCN guidelines. So those are some of the things we do. It's also a really excellent opportunity for us to become health coaches and talk a little bit about health, healthy lifestyle, exercise, diet, and so that again, with breast cancer patients, we're supposed to be providing survivorship care to 100% of our patients. That excludes stage 4 patients. They're typically coming in for ongoing therapy, so the other patients were doing a really good job. The Commission on Cancer right now is requiring 25% of our oncology patients in general receive that survivorship care plan, and that will be incrementally changing so that in 2019, 100% of our, except for the stage 4 patients, will be expected to receive a survivorship care plan. So again, that's a big component of what we do with our patients as well. So, this 3-phase process looks relatively straightforward, but for a breast cancer patient, their care may be surgery and radiation. They may be done in 3 months. For some patients, they're in care for up to a year, so obviously needs change with that. This is a little slide of what my coworkers feel I function like before I get to Bergey's in the morning, but really what this is to depict how our patients feel. You were very used to navigating the medical system, but I think all of us have probably been in a patient role, and when you get in that role, even if you have expertise in a particular area, you want information specific to the diagnosis that's being treated. So we try to help patients get beyond this. Skipped over a slide, sorry. I like this depiction of the navigator role. We have the patient tucked into the center, and on the periphery you can see all of the different services that may be involved in diagnosing and treating the patient. So there's a lot of information that's being exchanged. The nurse navigator's tucked in the middle, and I like to think of myself as a buffer. So just a liaison team member that's reinforcing information. Obviously, we don't feel that the team members aren't doing their job, so we need the navigator. But if you remember or think back to health literacy, patients typically need information in a variety of different forms, and I think it's a minimum of 6 to 7 times before the information sticks. So one of my jobs is reinforcing and finding information for patients as they need it. So again, the role of the navigator, we do use an electronic medical record. Any patient interaction starts with assessment of, the situation, where are they having problems, where are their questions, determining what barriers exist for these patients. And there's a lot of communication and education that occurs throughout a patient's treatment journey. So we've talked about barriers a couple of times. This is not an exhaustive list, but some of the things that patients encounter that could be problematic and keep them from getting timely care. So I wanted to give you some examples under each of these categories. So under financial, lack of insurance is one area that obviously is a problem. It's becoming less so with more accessibility to health care, but we have still had in the last year a couple of patients that have not had any insurance, and it does impact their, scheduling of tests, and so they sometimes need an advocate to help figure out how to get care quickly. Co-pays are another thing that really add up for our patients that are being seen weekly. Those things can be impactful. And just routine bills, when people run out of PTO and they go on short-term disability, they may not have all the finances they need to pay the rent, mortgage, and we go through the normal channels and make sure they're associated with correct programs. But I do also want to just make note that as of last year, we do have the Dr. Rhodes Compassion Fund, and that has been well supported and has been a real blessing to a lot of our patients that have those unexpected expenses, and we've been able to actually do a lot of really awesome things for patients because of that. Transportation's another barrier. You get a patient that's getting daily radiation for sometimes up to 6 weeks. We serve a 6-county area, so we have patients coming in from a fair, distance. So it may be the cost of gas, it may be that they just don't have transportation, so we will work with patients on bridging that gap. Communication, language barrier would be an obvious one here, using interpreters, Starfish, AT&T language lines. But again, just cognition of our patients. If you loop down to the psychosocial, the last barrier I've listed there, when people are under stress, they don't absorb information, they don't process the same as they normally would. So it's just trying to pick up on those things and reinforce and make sure that they understand what to expect. And then complexity of care is another thing. Breast cancer patient may have a pretty straightforward plan of care, from surgery to radiation to the other patient that has neoadjuvant chemo, then they have surgery, then they have radiation, they might have some PT peppered in there, followed by anti-estrogen therapy, so it can get long and involved for them. So how do we identify for patients what barriers exist, would be something some of you might be asking. The first thing is establishing a relationship. Again, my plug for early referrals. The sooner we get involved with patients, the more comfortable they are with you. Those patients that we follow throughout care, they'll tell you things that they may not, that sometimes you wish they wouldn't tell you, but sometimes you're the only person they tell. So that's important. And then we also do distress monitoring, which is, again, our go-to tool for figuring out what's bothering folks. So this is the NCCN distress monitor. We've adapted a little bit for our facility. It's relatively straightforward to administer the patients. Think about the last week, including the day you're providing the tool, and they assign themselves a level of distress, right or wrong. So we have them start by doing that, and then looking off into the categories onto the right and telling us what things are making that number high. This helps us to focus our information, education, and then make sure we're getting the right resources for the patient. We'll use this initially when we meet patients, but it's not static. We administer it throughout care because, as you can see, just the number of physical things listed on the screen. If a person's going through chemotherapy, sometimes things impact them, differently throughout care. So then we make appropriate referrals after we administer this tool. The distress monitor is now required of all patients by the Commission on Cancer. So every oncology patient right now that's at consult has this tool administered. It's right now scanned into the media tab in Epic. So if you're looking to see if your patients had one of these tools done, that's where it resides. If we get a patient that's scoring 4 or greater, we always report that back to the physician. And in addition to just reporting, hey, your patient has a level 6 distress score, we also let you know then what interventions we've implemented, what referrals we've made, and then if there's medical management needed beyond that, the physician's then aware. And you sometimes assume that you know what's bothering patients when you go in to meet them, but just as an example, had a 70-plus-year-old pancreatic patient that I got asked to see and used the distress monitor, and it was pretty obvious that his diagnosis was impacting and causing worry and stress, but he also marked physical appearance, and he was very afraid of losing his hair. And so you might not think that of a, we tend to discriminate a little bit against our males, but that was really important to him, and we were able to connect him with some resources to address it. So one of our objectives was to talk a little bit about what are some of the benefits of navigation. Obviously, improved coordination of care, making sure patients get connected with the right, components of care in a timely fashion. We've already talked about removing those barriers to care. Improve compliance. This is an area that what comes to mind for me are patients that are on anti-estrogen therapy. So that can continue for 5 to 10 years for patients. Some of them, because it's an oral pill you take once a day, they don't assign a high level of importance to that. If they start developing side effects, they may just kind of stop taking it and not really mention anything to the physician. So one of our roles is making sure that they know going in what are some of the side effects that can can be impactful. For our ladies that are taking anti-estrogen therapy, sometimes hot flashes, sexual dysfunction and side effects, things that they're not comfortable always just bringing forward, and they think that it's just normal and they should just accept that or stop the medication. If they know those things are a potential and also very treatable for patients, we can keep them on therapy, and it's a huge benefit, obviously, to the outcome of their care. So that's an example of compliance. The next two kind of go hand in hand. We want, obviously, to increase access to services for our patients, and then the benefit would be to increase internal referrals. So some of the things that we refer to our oncology nutrition program, lymphedema prevention and management. And when I get through my slide presentation, Katie Albright and Barb Wheelock provide bulk of our patient contact in that venue. So Katie's going to come and give you a little update on what we're doing for lymphedema prevention at the end of my talk. And then higher patient satisfaction. We don't administer an official satisfaction tool, but the feedback we get from our patients is that they appreciated having the contact and having a point person going through treatment. Okay, this is where I check if everybody's awake again. What do you guys think? Services performed, reimbursed? It's still coming in. Okay. Okay, so obviously most of you have been in healthcare long enough to know just because something's a benefit, it's not necessarily reimbursed. Hopefully that will change. We're really lucky at Mary Greeley with a lot of our programs. We have foundation support. But I guess the takeaway with this slide, if you're, a primary care provider and you think by referring to the navigation program you're adding cost to the healthcare system, to the patient's insurance, you're not. So hopefully we'll, increase patient outcomes but not be another cost. So then the last of the objectives was just talking about the referral process. I just made a short list of the places some of our referrals come from. You would expect the first three to make referrals. What some of you may not know is that we have our tumor registry, Carol and Brendy, that are on site, and so that's really helpful. So every week to 2 weeks they'll bring me all the new breast pathologies that have come through, and if I am not connected with a patient and they are getting treatment here, then I can touch base with the physician and say, is it okay if I see your patient? And then we get them on board and into the system. Okay, this slide's a little busy, but Tim tells me I can't use the laser pointer, so I'm going to use the mouse. But I just want to kind of quickly go through this. At time of diagnosis would be the preferable time for people to come into the program. These folks are usually the ones that are referring. We get most of our referrals here. Primary care, we get some, but we'd really like for this area to increase. We think that, at the time they're first seeing primary care, can send them over to our office. We can spend that additional 30 minutes to half hour, deal with anxieties, and get them into the program quicker. So after we see them, then these are the barriers of care that we can determine if they're having. And then that kind of jumps down to the referral section. We make referrals based on barriers. They don't come in at diagnosis. This is another common entry point into the system, so at time of consultation. Again, we'll see patients pretty quickly. We try to be as flexible as possible, see them same day, if need be, and if the patient wants that. Again, it jumps back up to figuring out what are their barriers, what are their needs, and making referrals. Some of the referrals we make, just to make note of some of the services that are available. We have on-site counseling now at the Resource Center. We have a psychology intern that provides counseling to our patients. We have the oncology nutrition program where patients can meet one-on-one with the dietitian, talk through any issues that they have in that regard. We have the WIG Foundation program that's supported by the Mary Greeley Foundation. So patients going through chemotherapy can get a free wig, and we do measuring and fitting for that. We do fittings for bras and prosthesis. And I know I'm lymphedema management and prevention, that's one of the other areas. Palliative care. Sometimes we need to pull in our social workers to help us out. And if I've forgotten any of the services, kind of feels like the Academy Awards will catch up to you later. I may have missed somebody. So that's what the current process does look like. So currently, we do keep a database of all the breast patients. Our navigation software and where we document is a freestanding software, so it doesn't interface with Epic. If I have a patient that's really complex, or as I said before, a distressed patient that the physician needs to know about, we have to cut and paste notes over to Epic. Our survivorship care plans are kind of tedious in communicating that to Epic. What I am excited to let you know is that May 9th we're expecting to go live with a bidirectional interface between Epic and Nurse Nav. So when that happens, the physicians will have this order that's displayed. I'm not sure if you can see that very well, but it will be in the physician preference list. So if you have a patient that's got a breast cancer diagnosis or you need navigation for your other oncology patients, you can simply check this order. There are 4 questions that we do ask you to address. Has the pathology been discussed with the patient? That's a lot of what I do, is go in depth reviewing pathology and telling them what that means to their diagnosis. Do they have a family history, so we can prepare for maybe they need genetic information? And are there complicating social situations? We had a couple patients that have relocated from different states. They come here, they don't have adequate housing support system, so it's nice to know those things going in. And when does the patient prefer to be scheduled? So this order will help alert us and make referrals easier. Right now, unfortunately, we're old school. You have to pick up the phone, call the Cancer Resource Center, call my extension, and we do have a fax referral form available, but we're very excited to have this order in the works. And then what that will do also is all my documentation will flow back to Epic. So under the Notes tab, you'll have access as physicians and other care providers as to what's going on with the patient as far as navigation services. So I think with that, I'm going to bring Katie down. One of the things when we were preparing for our accreditation, we realized as a quality study that we weren't referring very many patients for prevention and management of lymphedema. So that's one thing that we've addressed by putting in a order into Epic that's linked, I believe, to the ICD-10 code for breast diagnosis. That's not the way this order's going to work initially. But so Katie and Barb do manage that program, and I'll let you elaborate a little more. Which mic would you like? The Britney Spears fashion,
yeah.
or you do? Okay. How about the lapel one? It's easier to get off.
Can you guys hear me? Yes, no? I don't feel like I have it on. But
No. Well, here. Feel like Beyonce
I know.
without the leather.
Put that on. Oh yeah, that's very Beyonce.
Very
Thank you.
nice, huh?
Thank you. Okay, you guys can hear me? I won't take too much time. My name is Katie Albrecht. I'm a physical therapist, medical arts building with Mary Greeley. And as Angela said, as part of being designated as a breast center, we spent some time really carefully considering what the role of a physical therapist would be in identifying and addressing impairments to really minimize what what kind of longstanding functional limitation there would be for our breast surgery patients. And so what came out of that was essentially a best practice alert for all breast surgery patients to create a physical therapy referral. And that's something that can happen locally for the patient or here. They would come either to see myself, or if they choose to go to McFarland, they would see Barb Wheelock. And so we have sort of created a little protocol, I guess, for what we want that screening visit to look like. Because really it is a screening visit. We see it as an opportunity to identify early any problems that they may be having and provide them with more education. So the things that we're going to be screening for primarily is lymphedema surveillance. So we do take measurements on that first day of both arms and identify at that time whether or not we think lymphedema is present. And we go through quite a lot of information about what lymphedema is, what it is not, what to look for, who to contact, how to manage risk factors for lymphedema, et cetera. And patients have so far been really appreciative of that. They get in our clinic a little 2-page handout, and they feel that's a manageable amount of information to look at once. And so if at that time we identify that they would benefit from use of a compression garment, we'll make arrangements for that to be fitted at that time. We're also screening carefully for pain that we think is out of a normal context post-operatively, to see if there are things that we can do to help them manage that pain. We assess their upper body strength and range of motion, and give them a little bit more specific than what comes in the book, I suppose, exercises for how to improve and maximize their shoulder mobility. And then we also will give them a couple of questionnaires. One of them looks at it's the PAR-Q, the Physical Activity Readiness Questionnaire. A lot of our patients have questions about, when can I go back to my exercise program, or I never exercised before, but now I'm really going to be as healthy as possible, and I really want to start exercising. What should I do? And so we like to take that as an opportunity to set them up with an exercise program if it's appropriate, and help them identify what are their goals and what's the safest way to go about participating in an exercise program. And then we also will screen carefully for fatigue, especially for our patients who we know are going to be going through radiation. And we use that to help us guide what their exercise program should look like. We provide a lot of information about how exercise can help manage fatigue. So we're essentially one more stop along the way, one more piece of their journey, one more person for them to make a connection with and to provide resources for. Does anybody have questions?
Anybody have any questions for the navigation component?
So in general surgery, we make a lot of referrals to Angela, and she does a great job of coming to our department, actually, and she'll see those patients the same day that we're doing the surgical consultation with the patient. So it just flows really nicely for them. Angela, my question for you is, when we start putting this referral order into Epic, do you still want a phone call then to schedule a time for you to meet with the patient, either in your office or in our office?
Yep, good question. I think you guys can hear me. Yeah, we can actually, that will trigger in my navigation software. If you indicate on that fourth question when you want the patient to be seen, I'll look up their surgery schedule. So it should eliminate that phone call.
Okay, great. Thank you.
Yep. And Mindy brings up a good point. We can come to the patient. We see patients in the surgical area and over in medical oncology for primary care. it's nice if you send the patients over to the Cancer Resource Center, because then we can introduce them to where we are and if they need further resources down the road, and it's just good introduction. Anything else? Well, thank you for coming, and if you have any patients that you think would benefit from our services, please let us know. Thank you.